Okay, Assalamualaikum and a very good morning to everyone. So I'm Syakirin, respiratory physician from Institute Perubatan Respiratory Kuala Lumpur. It's just about 12 minutes drive away from KL Central, near to busy Bulatan Pahang and Hospital Kuala Lumpur. So I've been given a task to talk on challenges in addressing interstitial lung disease in Malaysia. I think Dr. Felix had excellently showed and told us about comprehensively on interstitial lung disease. I guess that is the simplest version of what is ILD all about. So some of the slide might be slightly repetitive. Hang on. This. So I'll be talking a little bit about ILD, which you have listened to Dr. Felix, but maybe slightly a little bit more simpler version, and the challenges and the need that we're facing. So as a general respiratory physician, we're not just looking after only one respiratory disease. So if you all know, all lung diseases, they are comprises of COPD, chronic obstructive pulmonary disease, a disease that costly because of smoking predominantly, followed by asthma. And then in my center especially, we are the National Tertiary Center for Complex Tuberculosis cases. And ILD is just one portion of all lung diseases. And from this, we have many more. So as what Dr. Felix mentioned, about 200 types, we're not looking after all the 200 types, but maybe the important one that commonly encounter in our patients. So it is considered rare disease as compared to other lung diseases. So if you look at the numbers, even in 100,000 population, it hardly reach more than 100 patients. So commonly actually being diagnosed is idiopathic pulmonary fibrosis. But however, in a certain region, we found other type of interstitial lung disease, and depends on the exposure of that particular country. Unfortunately, we don't have any Malaysia data as yet. We don't have a proper registry yet for interstitial lung disease, and I hope this will be in the future pipeline for ILD work. So IPF is the one that we are concerned because the prevalence is actually getting more. The reason being is because the detection case rate is getting better, in terms of you have more doctors that have interest in looking after ILD patients, and you have more and more radiologists that subspecialize in the thoracic radiologists who can pick up all the pattern of scar on the lung on the CT scan. And of course, other form of other modalities to diagnose ILD, and we're picking up the cases even more. And IPF is always associated with the elderly population, more commonly seen in men, and of course used to smoke. And as what mentioned, median survival is around 3 to 5 years. So this has been projected earlier. So a patient that actually presented even earlier than when they come to us for the first clinic visit. So actually the median survival was even longer as compared to when they first came to see the doctor for consultation. And if we look at when we have early pickup of the disease and we decided to treat the patient with some form of medical intervention, and we're looking at the earlier the disease has been picked up and the earlier the patient being treated, the outcome is even better. So our aim is actually to preserve the lung function. So if an example for IPF, a disease that is very devastating and you know is going to progress in whatever way with a various speed. So even if we put the treatment also is still progress, but the treatment will help to slow down the disease progression. Then that is our aim in total. So this is the estimation. So I've mentioned about IPF is an elderly disease, and this is taken from the statistics, Department Statistics of Malaysia. So we are actually already an aging nation. So by 2050, the population aged more than 65 is going to raise 15%, and now it's about 7.3. According to United Nations, anything above 7% is already aging nation. So these are the cohort of population that perhaps we are looking at. Of course, there will be small numbers of patients from this cohort may have developed interstitial lung disease, particularly IPF. And roughly about pathogenesis, how can a person get IPF? A lot of factors. So maybe genetically they are susceptible to get the disease, or there are also extrinsic factors such as smoking. So according to the national smoking prevalence that's recorded in 2019, we are actually surpassed more than 20% actually who smoke 15 years of age. So imagine in 20 or 30 or 40 years time, all these extrinsic factor will actually somehow have an impact to the lung, and later on it may become a disease, especially in a genetic susceptible person. In the end, they may get a disease, as particularly IPF. So the challenges and the needs. So just a few papers on the challenges, and of course, what make we pick up late. So basically, this is a analysis that coming from various centers, which showed that, as what mentioned earlier, all respiratory diseases patients come similar symptoms. They come with cough, they come with shortness of breath. No one knows this cough and shortness of breath belongs to the ILD. They can actually thought that this is because of their heart failure, and some of our elderly things because of their aging factor that cause them to have shortness of breath. So majority of them will never get ILD or lung fibrosis diagnosis at first instant when they first come to the medical attention. In fact, even the second consultation, third consultation, the diagnosis may not be picked up as a lung fibrosis. So there will be a huge delay, and they will put on treatment. The famous one would be bronchodilator treatment, and some of them may have been treated as a smear-negative tuberculosis and been given 6 months of anti-tuberculous therapy and waited for it to become better, but it is not. Then only we get clinched to the doctor or physician who attended the patient who may think of other diagnoses beside the one that they have made before. And the next one would be basically a survey on among the patient advocacy. So they found that lack of awareness, lack of knowledge, false diagnosis, and the diagnostic test is not really straightforward, especially if you're not thinking lung fibrosis or ILD from beginning. And of course, that will actually end up with delay to the referral to specialists. And of course, this delay can lead to poor quality of life. Patient will not get the early medication that they're supposed to get, and it causes early mortality. And often this has been emphasized over and over again. Why is it delayed? Because this is not being picked up as a disease that is common. You know, it will be actually diagnosed with something else that more common among our community. And then that will actually lead to a delay in diagnosis and exposed to a lot of unnecessary tests and a lot of unnecessary treatment. So this is the steps. So this is from local settings. So how do we actually get our patient from referrals? So I'm in the tertiary center, so I'll get referrals from various stage of healthcare facilities, from primary and secondaries, and from Ministry of Health facilities, and also private, and also Ministry of Education. So the first is actually the clinic visit. So if the patient presented to us with all the work, the investigation had been done in the previous clinics, that makes our life easier. But however, not all patient has the privilege to get all this necessary tests being done. So what we'll do, we'll schedule a lung function, 6-minute walk test, CT scan, and all this will take some time, will not get over a day. So sometimes even weeks or months, depending on where we are practicing. And after all this information gathered, then we will discuss in multidisciplinary discussion to formulate a diagnosis. Some of the cases we might actually formulate without doing a biopsy, and some of them may actually be subjected for biopsy. And later on, we will decide on the treatment depending on what is the consensus from the multidisciplinary discussion. So the challenges is always at the disease, the test, and the treatment. So as we all know, in our country, we have difficulty. Number one, the disease is very rare and it's not easy to diagnose. And not all clinicians are familiar with this interstitial lung disease or lung fibrosis. And there goes the delay. And of course, we have limited doctors who actually have the special interest to look after all these patients. In terms of the tests, again, difficult. Some of the basic tests is available in our Ministry of Health facilities, but some of the tests we need to outsource, especially for extended connective tissue panel. And some of the tests are not done in our government facilities, that we have to get our patient to spend their own money to pay at the private lab. And the advantage in doing in private lab, of course, the turnaround time is very fast. You may get the result within 3 to 5 days, 3 to 5 working days. And that will expedite all the workup for the patients. And then, because the lack of availability of the test in our government setting, so that will cause the delay, and hence the delay of diagnosis will go to the delay of getting the treatment. In terms of the treatment, it's difficult. It is not available in all Ministry of Health facility, only in a subspecialized center, particularly tertiary center. And this is one of the reasons it caused a delay to get the treatment. The accessibility is not easy because, especially when we're talking about antifibrotic, it comes with a huge cost to the Ministry of Health. So we will go for other means of fundings besides just MOH budget. So it depends on if, let's say, the patient is pensioner, so we use the pensioner funds, or if the patient is Muslim, then we use a zakat or Baitumal funding to get the treatment. But again, this process is not happen within weeks, days or weeks. It may take even months, sometimes half a year to get to the funding and purchasing the medication. So that will cause the delay starting the treatment. And of course, that this is due to the limited access to the treatment. And only antifibrotic that actually in our formulary is nintedanib, and that is only licensed for idiopathic pulmonary fibrosis. Apart from that, we have to actually get approval from our DG. So that another process. So after that step already passed, that will be around 4 to 8 weeks, depending on the locality. Then only you can work out on the funding. So that's where the delay will be. So we need element, the people, the process, and the tools. Of course, the one that I listed is the ideal one. So you want respiratory physician, especially those with a special interest in interstitial lung disease. We want radiologists, particularly those who are actually have a subspecialty in thoracics. At this present moment in the country, we have 2 certified thoracic radiologists to cover all over the country. And we have, I think, few of the trainees, and I hope soon we will have a huge community of thoracic radiologists, hopefully at least one in every state. We have 2 certified pathologists in thoracic, one in East Malaysia and one in Klang Valley. And rheumatologists, I guess there are quite a number of them. Every state, I think they have at least more than one rheumatologist. And thoracic surgeon also is considered very rare community. We do have palliative specialists to help us, primary care specialists in clinic kesihatan, or in fact the general practitioner clinics, medical officers, pharmacists. All these are an important stakeholders. And not to forget, when you talk about something to in future for advancement involving clinical trial researchers, so you need a clinical research officer as one of the people in having to get an improvement in our service. So there are a lot of process. So from the beginning, you were been listening about the delay of getting the diagnosis first, then another delay to get the treatment. So the process will start from the multidisciplinary meeting, and then working out how to get this medication, especially the expensive one. So if let's say for antifibrotic, we have 2 in the country, 1 in the formulary and another one is not in the formulary. So that the one in the formulary costs about 42,000 a year and another one is 50,880 ringgit a year. So that amount is impossible to be spent by our patients. So we need to help them. Another concern is access to the CT thorax. Although every major hospital has a CT scan machine, but you must remember the bulk of this disease is very small as compared to other cancers, any surgical cancers. So we have to compete with all these cases. So whenever we have a thoracic radiologist, the importance of ILD will put up front. So they know what we want. They know how urgent we need to get to the diagnosis of ILD. So it will be given a priority. So some of the cases also require biopsy. And not all we actually subject patients for biopsy. And this is only in certain centers that doing a proper lung biopsy that will actually will give a high diagnostic yield, because to diagnose ILD histology, it needs a specialized equipment and it needs a special people to read the biopsy report. And we have many more. So a long list of process. And when we go to the tools, it is also needed. A good CT scan machine that can do the HRCT protocol, the full lung function test with the proper modalities. And you have also patient that going for a pulmonary rehab, they should get a proper, the lab should have equipped with the proper pulmonary rehab items. And then the blood test that I've mentioned earlier, some of the tests can be done in our facility and some of them we need to outsource. And it also depending on patient whether they can actually pay or not. And then pharmacy is one of the big concern in the tools. So the access to the drugs, antifibrotic and also some of the expensive anti-inflammatory. So the challenges come, lack of disease awareness among the people. So since we have not many respiratory physicians who has special interest in ILD, so you can even imagine a doctor besides respiratory physician, that the disease is very rare and not many will think of this at first instant when they actually see the patients. And of course, as I said, not many of us that actually has interest in ILD. So we come to process. We don't have an established guideline at this present moment. So we actually adopt the international guideline in our local practice, but it will be good to have our local guidelines. And there's no established very good MDD in all centers. So we only focusing in Klang Valley, but the rest of the region may not have the privilege to have this and established discussion. And delay process in terms of getting the appointment of CT scans and poor access to get the CT scan, especially a primary care doctor who can pick up this is lung fibrosis, but they cannot actually get a CT scan right away. So they have to refer to tertiary center. And the tools, of course, incomplete facilities. As I said, not many blood tests is offered in our government facility. Inadequate funding, this is always something that we always cry and I don't know what to say anymore every year. And then limited resources, of course. This is also that people keep on harping and persuading it's okay to work in a limitation, but you have to work on it. So that's why I still stay in MOH. Okay. So the respiratory clinic in MOH, so this is where I work. So I am fortunate enough to stay in a busy Bulatan Pahang, but not to say it's very near, but if you look at the distance, it's not that far. They only make it far because of the heavy traffics. That's all. So we have a national heart center that provides a cardiac MR and PET CT scan. So for one of the ILD cases, or we need this imaging modality to diagnose and to follow up the patient. We do have a HKL that provide the lab test, the basics one, and also genetic test, genetic lab actually, that provide the service to extract the DNA. Then the test we're going to send out to overseas. And of course, rheumatology, palliative, and radiology imaging in a Kuala Lumpur hospital. And private lab is just nearby at the back of my hospital. And KKKL is the primary care facility. So the primary care doctors can always refer to tertiary center. So we're talking in the Klang Valley, so-called the ideal one. So the rest of the country, so we have 41 of us, but only about 5 of us went for a proper training for interstitial lung disease. One left to private and left with 4 of us still in MOH. So apart from that, we have other respiratory physicians coming, working in Ministry of Education, all the universities, Ministry of Defense, and also private hospitals. So this is the holistic approach of ILD. I wouldn't actually need. So in what Dr. Felix has mentioned, so the recommendation to start antifibrotic therapy early when it diagnosed is pretty crucial. Actually, it should be started in any stage of disease, regardless whether it is still normal lung function or definitely you will start mild to moderate, even the fact to when they come at the severe stage, as long as they can tolerate the medication. Number one. Number two, in our context, the funding is there, especially if they are pesara. So we have a technology review by our MOH on antifibrotic for treatment of IPF. And this is our blue book of formulary ubat KKM that listed nintedanib 2 strength, 100 and 150, licensed only for IPF at this present moment, waiting for approval for scleroderma, interstitial lung disease, and progressive fibrosing ILD. A lot more of medication besides antifibrotics to be used in ILD, so all come with a cost except for corticosteroids. That one's very cheap. Okay, so why do we need to address the challenges properly to confirm the diagnosis and make sure the timing referral? And because treatment, there is a treatment available that effectively to slow down disease progression. And of course, early intervention proven to improve the outcome. And of course, a lot of ongoing trials happening in our country. I think my colleague will tell you after this. And of course, the most importantly, the patient is to be given the opportunity to make the most of their remaining life. Thank you so much.